Good morning. Thank you very much for joining us today. My name is Jim Welch. I'm the Clinical and Operational Lead Nurse for Mental Health Liaison. And today we'll be covering the topic of depression and depressive disorders. So I'll just introduce you to my colleague, Emily.
Hi, my name's Dr Emily Rackley. I'm a psychiatrist that works with the Mental Health Liaison team and also with the older adult community mental health team.
Thanks, Emily. Thank you very much for your time today.
No, not at all.
So I guess for the benefit of our listeners, first question is, what is depression?
Yeah, and it sounds like a really daft question because people kind of think they know what depression is because it's talked about a lot in kind of common parlance and things. But I think it's really important to remember that depression is a mental illness.
Yes.
It is common, of course, but I think a lot of the time people can sometimes confuse depression with sadness. And sometimes we'll talk about people having low mood, for example, but that's a little bit different from depression. So when we think about depression, it's kind of a syndrome, if you like, so a collection of symptoms. And usually we kind of think about them, generally speaking, kind of you have like three core symptoms and then you have sub-symptoms. So your three core symptoms is your low mood. It's also what we call anhedonia. So that's kind of a real lack of enjoyment in doing activities that you would normally do. So not being able to get pleasure out of things that you would normally do.
So the things that would normally bring joy to your life.
Yeah, exactly. Yeah, exactly. So, you know, if you're a bookworm, you're kind of not wanting to read because you don't enjoy it anymore. So things like that. And then the other core symptom is fatigue, low energy. So those are your core symptoms. In order to say that someone's got depression, they have to have had at least two of those symptoms, and it has to have been for at least 2 weeks. So someone might have had a bad day, they might be kind of feeling low in mood, feeling really fatigued. That doesn't mean it's depression. It has to be there on most days for over 2 weeks. Also, to say that it's a depression, you obviously have to have those two core symptoms, but you have to have some of the other symptoms with it as well. And that's other things we see. So things like not being able to concentrate on things that you would normally, so kind of not being able to kind of follow the plot of a TV program that you would normally watch, or not being able to kind of concentrate on a book you're reading. Things like change in appetite. Some people will find that they completely go off food and sometimes they can lose weight that way. But also some people will find that their appetite increases, and particularly when they're trying to find kind of real kind of carbohydrate, sugary kind of things. Essentially, it can be a way of kind of trying to stimulate some kind of feel-good chemicals, essentially.
Looking for that artificial energy that's lacking.
Yeah, exactly. Yeah, so there can be a change in appetite, there can be a change in sleep. Again, can go kind of either way. Some people find that they're sleeping a lot. Generally, that's because of that core symptom of fatigue. They can be sleeping a lot. But also because if they're not getting enjoyment out of things, it can almost be a boredom sort of thing, a way of spending time. But sometimes it goes the other way as well. So some people will have what we call early morning awakening. So they'll have something where they will find that they are just waking up at, say, 4 o'clock in the morning, not being woken up by anything. It's not because dogs are barking, alarms going off. They're just awake and not able to go back to sleep.
Because there's an element, isn't there, that we are biologically programmed to wake as the sun comes up.
Yeah, exactly.
But actually in depression, people are waking before
They're waking up before that.
Trigger.
Yeah, exactly. And we do find that depression can sometimes be worse in the morning when that sort of thing happens. Other things that can happen, kind of more your psychological symptoms. So things like having low self-worth, low self-esteem, can be things like, as we said, kind of concentration as well. Just generally really not feeling good about themselves as a person. Sometimes that can progress to a point that becomes suicidality, so wanting to end your life. That's really common. A lot of people don't think of that as common. A lot of people don't talk about it. We're starting to talk about it a little bit more now. And we'll talk about it a little bit more in kind of the other sessions, but there are different ways of thinking about suicidality. It's not always actively planning to end your life. Sometimes it can be a thought of, I just don't want to do this. I just don't want to wake up. So they're not planning it, but we would call that a suicidality as well. So when we're thinking about depression, so you have to have two of those three core symptoms we said at the beginning, and they have to have at least two of those other symptoms to go with it as well. And we can also think of it as kind of, is it a mild depression, moderate depression, severe depression? that's just a way of us working out how many symptoms of depression have you got. So mild depression, you've got 4 symptoms, and then it kind of goes up.
Okay. Can we just return just to sleep just for a minute,
Yeah,
if you don't mind? Just to ask you about initial insomnia.
Yeah. So initial insomnia, so that's when people are struggling to get off to sleep rather than waking up. That can happen in depression, but often we find that can be more of an anxiety type picture. But what we know, depression and anxiety are their cousins. They so frequently coincide with each other. So sometimes people will have an initial insomnia, but if someone is coming to me saying that that's an issue, they're just not able to get to sleep, I'd want to know why that is. Is it that there's, kind of sleep hygiene sort of things? Are they watching TV really late into the night? Are their lights on? Is it loud? Or is it more of an anxiety type picture where they're finding they're ruminating, so they're going over lots of things in their head, and that's stopping them from falling asleep? So it's less of a depression, but it can certainly go alongside it if there's anxiety along with the depression.
That's really helpful.
Yeah.
Thank you.
And also just to mention, at the severe end of depression, very occasionally people can have what we call a psychosis with it. So you might see when we're talking about severe depression, we'll say severe depression with or without psychosis to kind of delineate that. This is more common in older adults, so the population I look after in the community. And that's when occasionally they'll start to have hallucinations. It's usually auditory, so they're hearing things. It's not the same as someone having a schizophrenia. The hallucinations are different. So often they'll hear a voice talking to them, telling them really derogatory things, that they're a bad person, that bad things are happening to them or their family. They can also sometimes have delusions, and again, they can be quite classical things in depression, and again, they sort of fit with a low mood, so they're all negative sorts of things. So very classic ones are thinking that their family has died and they can't be reassured that that's not the case, thinking they have no money despite evidence to the contrary, thinking that their house is going to be taken away. Very occasionally, they can have specific delusions, what we call a Cotard syndrome, where they occasionally will think that they have died or a part of them has died, and they honestly believe that. So that's kind of your real severe end of your depression that is less common that you'll see, but it does occasionally see, and that comes to the attention of psychiatrists.
And I guess important to reflect that for the sufferer, for the person experiencing, they are, the hallucinations are actually experiences.
Yeah.
They are hearing those voices as you and I are hearing each other now.
Yeah, exactly. They could point to where it's coming from.
And the delusional belief, you define a delusion as being a belief firmly held, not amenable to reason, but outside of normal societal constructs.
Yeah, exactly. So an example, I've had a lady before who was asking why I was talking to her because I was interrupting her funeral because she'd died. Despite that, obviously, there was evidence to the contrary because I was quite clearly talking to her. I could prove that she was alive. But as far as she was concerned, no, she had died. Her depression was that bad that to her, she was dead.
She was dead.
Yeah.
So I guess really important to stress that depressive disorder, depressive illness is very much an illness with a clinical set of symptoms.
Yeah.
It's not that sadness that
Exactly.
all of us experience at some point in our lives.
Yeah, exactly. I think it's really important that we don't pathologise normal human experience and normal human emotion. Bad things will happen to us and we will have a reaction to that. We will feel sad. That's perfectly normal. We do sometimes get referrals for, we've told this person really bad news and they're really sad. Can you come assess them for depression? As well, no, they've just felt sad, so they have one symptom and it's just today. So you don't have that 2 weeks.
And if, putting myself in the position of not being an expert, what tool would I use to assess somebody for a depressive disorder? Yeah,
so it can sometimes be really hard to kind of remember what are those core symptoms, what are all those different symptoms. There's quite a few different tools that have got quite good evidence. One we particularly use is something called the PHQ-9, so that's the Patient Health Questionnaire 9. Really easy to use. You don't need training for it, which is really, really helpful. And that is a really good way of kind of taking you through all of those different symptoms of depression that's really easy to follow and gives you an idea of, is there a depressive illness? And if there is we talking, is it mild, moderate, severe? So that can be a really good way of helping people who aren't used to assessing for depression to get an idea of where that person might be sitting.
Now, right, thinking there's also there's another one. There's the hospital anxiety and depression questionnaire.
Yeah, absolutely.
Which
Yeah,
again is more sensitised towards people who are having an admission to a hospital bed.
Yes.
And there's also a tool for older adults.
Yeah, there is. So there's the geriatric depression scale. One of the reasons we have a specific one for older adults is when you look at the PHQ-9 and certainly thinking about the symptoms of depression, things like having low levels of energy, having poor sleep, having poor appetite, that's not really very helpful in the older adult population because
much of that is ageing.
A lot of that is part of the normal ageing process, or because they're frail, for example. So the geriatric depression scale takes away a lot of the more physical health-based symptoms of depression and helps you focus more on kind of what's happening with the person's thinking and feeling. That's a little bit more specific for older adults.
For the benefits of everyone listening to us today, those tools will have been uploaded to the vulnerabilities pages of the intranet. So go to the internet browser, type in vulnerabilities, and it'll take you to the portal. And from the portal, you'll find mental illness, and under that label, you'll find the relevant assessment tools. So I've heard the terms endogeny, exogeny. Internal, external, as being causes or underlying principles of depression. Could you describe that for me?
Yeah, so that's a way of kind of thinking about what are the causes of depression. So I like to think that there are kind of two ways of framing what causes depression. Is it endogenous or exogenous? So by that I mean endogenous, within the person, exogenous, out with the person. Sometimes you can think of it, is it biological, psychological or social? So if we look at endogenous and exogenous, if we think exogenous, kind of out with the person, that's when there's been some external factors that are affecting the person's mood and causing a depression. So that can be things like, as I said, something's happened, maybe they've got bereavements have happened, bad employment, social situations, kind of what are their kind of social situations like, kind of relationships, those sorts of things. So it's all things outside of the person.
Yeah.
They can all be kind of risk factors for a depression and can be causes of the depression. As opposed to someone that has an endogenous depression, there isn't something obvious that's kind of happened that's sort of triggered the depression, if you like. So we'll talk about kind of like what's triggered your depression. For some people, there isn't anything. Some people, they've just been unlucky and they have developed an illness and they've got the depression. That's more common in people that have got things, if they've had depression before, it's more likely for that to happen. So if they have a recurrent depressive disorder or if they have something called bipolar disorder, so that's when they have depression and episodes of mania, they're more likely to get a depression, not because anything's happened, but because that's what the pattern of their illness does.
And I think we'll come on in a later episode to talk about bipolar disorder and also schizophrenia, which you mentioned earlier on. So in looking to assess somebody with a depressive disorder, you're looking not only at the person in front of you, but you're also looking at their wider social, economic, family, for those trigger factors.
Yeah, exactly. So that's when we're thinking kind of what are the biological, psychological and social factors to this person. So the biological factors, that's kind of what is happening for that person. Have they got an underlying, disorder that will mean they're more prone to depression, like recurrent depressive disorder, bipolar disorder? Have they got things that kind of more medical that might be causing them to have low mood that turns into a depression? So things like, have they got hypothyroidism? Are they getting episodes of hypoglycemia? All those things can really affect your mood as well. Also, just having chronic medical health problems makes you more likely to have it. Things like chronic pain as well can make it more likely. So that's what we think about when we think kind of what are your biological causes. Your psychological causes, that's when we're thinking about kind of how does that person think about themselves? Do they have any kind of automatic, kind of unhelpful thinking, for example? So if something bad happens to me at work, for example, I think, well, that was rubbish, I move on, I don't dwell on it. But for some people, if they have a depression, they've got that automatic negative thinking. Something bad happens, they might automatically think, well, I deserve that, I'm a terrible person, for example. So that might be causing them to be more prone to having depression.
We all have that internal dialogue, don't we? We all decode the world in our own way and see reality differently. But equally within that, we can be prone to using predictable thought patterns
Yeah, exactly.
that we've got more used to.
Yeah.
I guess psychologists call it a schema,
Yeah, exactly. Yeah,
which is
exactly.
a model of decoding the reality around you.
Yeah. And often that comes from how we've grown up, what we've been like as children, what the environment's been like as children, what were our parents or our caregivers like, were we taught about our emotions, that sort of thing as children. All of those things kind of will factor in kind of what are the psychological situations, that what's causing this person's depression, what's making it more likely for them to have a depression.
And certainly now I think we're far more aware of ACEs, or adverse childhood experiences.
Yeah, exactly.
And the effects that those can go on to have later in life, well, either in childhood or later in life as an adult.
Yeah, absolutely. And those are often the kind of the psychological factors that, they do make it more likely that you'll have a depression. The more ACEs you have, the more likely it is that you will develop a mental illness, including depression, as things go on. And you also mentioned kind of employment and the person's social structure. So that's kind of the social factors of the person's depression. So have they got much social support? Are they kind of living by themselves? Are they able to get out of the house? So that's something I think about as an older adult psychiatrist. Are they actually able to get out of the house, for example? Have they got employment or meaningful kind of activity and occupation in the day? What are their finances like? Are they depressed because actually they've got no money? They've not been able to get their benefits sorted, all of those sorts of things. So those kind of the social kind of risk factors for someone's depression.
I know it's quite interesting from a liaison point of view. We saw quite a significant spike in people presenting with acute crisis in result of the bedroom tax.
Yeah,
for instance.
exactly.
People were threatened with losing their family home where they built their entire life.
Yeah, exactly.
But couldn't afford to maintain that.
Yeah.
Because a change in government policy resulted in illness in some vulnerable people.
Absolutely. Yeah, absolutely.
So I think we've all become very familiar with the word depression. Perhaps you could argue it's used a little too interchangeably with sadness.
Yeah.
How many people would be diagnosed, say, on an average year?
Yeah, so unfortunately, it's really difficult to work out exactly how many people are diagnosed with depression, because not everyone who has depression will seek medical attention for it. So there's probably lots of people out there with depression that we just don't know about. And also depending on how people are diagnosing depression, because there are, as you said, kind of there's different rating scales. Kind of, is it a GP or a psychiatrist? Have they got different ideas of how to diagnose depression? It'd be really hard to work out exactly what the figures, but the most reliable figures that certainly that NICE use anyway, is that within an adult's lifetime, there's around 15% of those people will have a depression within their lifetime at some point.
So 15% of adults?
Yeah, around about 15% of adults will have a depression at some point in their lifetime. So I know a lot of people kind of bandy about the 1 in 4 figure for mental health. We think it's about 15% for depression, because there's obviously lots of other mental illnesses out there. But depression it's the most common one. It's twice as common in women as it is in men. We're not entirely sure why that is. There's some hypotheses that it's just a fact that women are more, generally speaking, they're more likely to go to the doctors. So they're just being diagnosed more. There's also some theories that it's more to do with kind of the social structures. So when thinking about kind of gender inequalities, sometimes we think that might be why that women experience depression more. But as much as the research can tell us, we think women are twice as likely to actually experience a depression. And the research also tells us that the average age that someone would develop their first episode of depression is about 25.
Okay.
Obviously, it can be hugely variable. Some people are really unfortunate and have it as a child. Some people don't have it until they're an older adult. There is a second spike of people that kind of develop it in kind of their sort of 50s, 60s, if they've kind of never had it before. But generally speaking, most people have their first episode at kind of mid-20s.
I guess that'd be frightening at any age, but if you've lived your life, you've got to your 50s, you've got to your 60s, all of a sudden, your mental wellness deteriorates. That must be a really frightening experience. Yeah,
it can be. And a lot of that we find, sometimes it can be kind of the social stuff that's going on. So I certainly find that sometimes retirement can be really difficult for people because they've lost their kind of their social structure, if you like.
Yeah.
It can be a complete change. Also, that's the sort of time that, maybe there's, unfortunately, people are becoming widowed or divorced as well. So those sorts of things become more likely as they get to kind of the 50s and 60s as well. But yeah, it can be frightening for people that have never experienced any kind of mental health problem before and then suddenly start to get it in their 50s and 60s.
I've read some research which suggests women are something like 6 times more likely to be prescribed antidepressants than men, and men are comparatively far more likely to abuse alcohol and drugs.
Yeah.
Is that your experience?
It's difficult to say, and certainly my experience isn't a general population experience, because I work with a select group of people. I work with older adults and people within the hospital.
Yeah.
But certainly we know that men are more likely to abuse alcohol than women. We know that that's the case. However, it does look like women are starting to abuse alcohol more, especially the younger women. So when I say young, I'm kind of talking kind of in their 20s again. That seems to be becoming a little bit more common, that's creeping up. In terms of being prescribed antidepressants as well, I think that's more of the factors what I was saying before, that women are more likely to seek medical care. So they're more likely to go to their doctors if they've got symptoms of depression, and therefore are more likely to be started on some medical treatment for it.
I think perhaps important to reflect as well that as a mental health service, or as the NHS mental health services, we've now put mental health experts into GP practices, prescribing senior nurses into GP practices, so that prescribing can be more appropriate, more targeted to the needs of the individual. And that's something called the additional
roles and responsibilities.
Responsibilities, yes, thank you.
So
rather than seeing a GP for what is ultimately a 5-minute consultation, a very quick diagnosis and perhaps a prescription, a longer sort of 45-minute interview based on the clinical evidence available and a targeted prescribing.
Yeah, exactly. And that's probably a good time to start talking about kind of what do we actually do to treat depression. So within that consultation, they'd be thinking about kind of what are those different causes of the depression. And we know with so many different medical things, the best treatment is to treat the underlying cause.
Absolutely.
So you might kind of hear in the news that antidepressant prescribing is going up. Sometimes antidepressants aren't always appropriate, and certainly they're not recommended for a mild depression. We wouldn't be thinking about giving someone an antidepressant. Instead, we'd be looking at, are there the social factors that this person needs help with? So do they need putting in touch with somewhere like the Citizens Advice Bureau or other kind of third sector to help with employment, finances, all of those sorts of things.
The practical.
Yeah, exactly. And also the evidence is that the psychological stuff, that's first line. And when I say the psychological, we're talking about talking therapies. The main one that's used is something called cognitive behavioural therapy. Really good evidence in depression, and that's the first line treatment. Before someone starts on antidepressants, we should be thinking about cognitive behavioural therapy.
So just to split that down for me, so cognitive thought, behaviour, the things that we do.
Yeah, exactly.
Therapy, working on the interrelationship between the two?
Yeah, exactly. So cognitive behavioural therapy, it looks at the kind of the different links between, so as you said, cognitive, so the way that person thinks, so have they got that automatic negative thinking? The behaviours, so are they doing anything with their day? Have they got structure to their day? And how those relate to our emotions as well. So cognitive behavioural therapy looks at tackling the cognition and the behaviour to help improve the person's emotional well-being.
Because if we can change the model that we talk to ourselves with or decode the universe with, then we can change our feelings. Our feelings are a consequence of our thoughts and our behaviours.
Exactly. And then as someone's feelings and emotions improve, their cognition and behaviour will then improve as well. So instead of that person being in that downward spiral that people can get into, hopefully we can then reverse that, and then they continue getting better.
And nationally, from a mental health services point of view, we have talking therapies, which people can self-refer to, or they can be referred to either by a GP or by a healthcare professional. So initial assessment would normally be about 2 weeks, and then depending on the needs of the individual, they could wait anywhere from 6 weeks to 3 months if it's more targeted therapy.
Yeah, exactly, and that they're able to tailor how intensive that therapy needs to be for that person. So for some people, it can be directed self-help, so the person is helping the person kind of get better themselves. Sometimes it's over a telephone. Some people need that more intense kind of face-to-face contact.
And some good evidence for what's called e-CBT as well, so online CBT.
Yeah, so that is becoming more common. It was really helpful during COVID, during the pandemic, and it's it's exactly the same model as previously we used to use books.
Yeah.
It's exactly the same sort of process.
Yep.
So it takes someone through the theory of cognitive behavioural therapy, and it helps them be able to do that therapy and helps lead them through in kind of a really nice, measured, and kind of gradually building up sort of way, rather than kind of giving them all of the information at once that we know that people won't be able to take in, especially when they're depressed.
Yes. So for the benefit of people listening to us today, we will have uploaded a series of books called G-Coil, or Gaining Control of Your Life, to the vulnerability section of the intranet. You'll find them there, and those are paper versions of CBT that someone can use for self-help if they're in hospital. But again, any sort of concerns relating to that or a person's mental health, please call the liaison service and we'll be able to advise.
Yeah. So we've spoken a little bit about kind of the psychological things that are out there. It is important to touch on medication because a lot of our queries come about different antidepressant medications.
Absolutely.
There's lots of different antidepressant medications out there. And sometimes you'll find that some doctors will prefer other ones over others that isn't necessarily kind of evidence-based. What we do know, the best evidence for a first-line medication is something called an SSRI, so that's a selective serotonin reuptake inhibitor. Serotonin being one of your neurotransmitters, one of your brain chemicals that helps us basically feel good.
Yeah.
So what those medications do is they essentially ensure that you've got a little bit more of that going on.
They kind of preload the synapse, don't they? To ensure that there's enough neurotransmitter to cross the divide between the axon and the dendrite.
Yeah, exactly. That's not to say that depression is because you don't have enough serotonin. Sometimes people think that, well, if we're giving serotonin for depression, that means that you don't have enough serotonin. That's like saying that a headache is caused by paracetamol deficiency. It's the same sort of process. It helps, but that doesn't mean it's the cause.
Yes.
So some examples of those medications that people will commonly come across, things like sertraline and citalopram. Those are probably the most common ones. They're safe medications. Sometimes we might think about if someone has got kind of a low sodium level in their blood, so one of the salts in their blood, sometimes it can lower that a little bit more. Sometimes for some people it can cause a slight increased risk of bleeding, but only if they're also prescribed something else that increases that bleeding. Usually it's not just those medications that do it. People also sometimes worry that they're addictive. They're not addictive. It's not a case that once you're on them, you never come off them. In fact, there is evidence that we can get people off of these medications. Generally, if someone has had a depression, one episode of it, and they've got better on those medications, we usually recommend to stay on them for 6 months until after they've got better, and then very safe to come off them. The reason we don't want to do that before is we don't want that person to then have a rebound depression.
Yeah.
If they've had more than one episode, then we generally say stay on them for 2 years. So be well on the medication for 2 years. Then we can start to think about coming down on them. We also say to come off them slowly, don't just suddenly stop them. It's not that you have a withdrawal from them, like someone who's physically dependent on another substance like an opiate or an alcohol. They're not physically dependent, but sometimes it can make people feel worse if they suddenly stop them and they're at a high dose. It can make them feel quite jittery and anxious.
And there can be a delay with that.
There can be sometimes. So often it will be a case of, if you've forgotten your medication in the morning, you don't have it till the next day, you're not going to get the kind of what we call a discontinuation symptoms. Usually it will be a few days. It depends on what medication you've had and how long it takes for that medication to actually come out of the body. So if someone is struggling with that, we might change them to something that just takes a longer time to get out of the body. So there are ways of managing it, but the best way is to just come off the medications slowly and with a doctor supervising it as well.
So you'd never advise someone simply to stop their medication in one fell swoop, as it were? No,
absolutely. It's a good way of making yourself feel quite rubbish. There are other medications just kind of that people might come across in people's notes. So things like mirtazapine. So that's something we use quite a lot more in the older adult population as well. It's less likely to reduce people's sodium. So that's one reason why we quite like it. It also has a funny side effect where at low doses, it can make people a little bit more sleepy and it can increase people's appetite. So sometimes it's quite helpful just from a side effects point of view. However, as you increase the dose of it, those side effects tend to go. But sometimes that can be quite useful in older adults.
So it's an unusual drug, isn't it, in that you get less side effects when you take a larger dose?
When you take a large dose, exactly, where it's the other way around. Other medications, there are ones that act on the serotonin and also your noradrenaline. So those are things like venlafaxine and duloxetine. You might see duloxetine being prescribed for pain as well, and also for bladder problems as well. So often I'll find that though it's not first line, if someone's already on that for pain, then if they are also depressed, I might consider just increasing that medication because they're already on an antidepressant, they're just not using it as an antidepressant. So those can be quite helpful as well. You've also got the tricyclic antidepressants as well. So amitriptyline, nortriptyline, those are the ones that we most commonly come across.
An older family that...
They're old-fashioned drugs. They can be more dangerous in overdose. So if someone's at risk of overdosing on medications, we really don't like it if they're prescribed those. And also they can make people quite sleepy. Sometimes they can increase the risk of falls in the older adult population as well. So we tend to try and avoid them if we can in the older adult population. It can also make those in the older adult population more confused as well. So we try and avoid them if we can. And that's why we generally don't recommend them as first line. Usually I'm thinking about those as kind of my second, third line options for people.
Something to come to later if the earlier ones haven't worked.
Yeah, exactly. I wouldn't expect a doctor who isn't a psychiatrist to be starting nortriptyline or amitriptyline for depression.
Yeah.
The other treatment to think about when we're thinking biological treatments isn't an antidepressant, isn't a tablet, but it's very old-fashioned. That's electroconvulsive therapy, which a lot of people don't realise that we still use, but we do, and it's got really good evidence behind it.
I know one of the things psychiatric nurses often say, if I get severely depressed, please give me ECT, because we know it's actually one of the most effective treatments.
It is, and it's one that works quickly. So we're not having to wait for medication to get into someone's symptoms. They can get better. We can see an improvement within a matter of a week with it. We only really use that in the very severe end of cases. So that's when depression becomes life-threatening. And it does become life-threatening for some people, which people don't always realise. But sometimes it can either be life-threatening because their suicidality is so much that they are actively trying to end their lives. But also it can be a case that their appetite and their lack of energy has become so bad that they are just not eating or drinking at all.
They've lost their functioning.
Exactly, and that can become life-threatening for some people. So in those situations, we don't have time to wait for medications to get into their system. So that's when we'd be looking at electroconvulsive therapy. It's a safe therapy. Sometimes people do get some short-term memory loss, and that's the main symptom from it afterward. Again, evidence is that comes back, that improves. The other main side effects are because you have to be put under a very short anaesthetic. Most of the side effects are due to the anaesthetic.
Yes.
But generally speaking, they're only under an anaesthetic for 10 minutes maximum. It's incredibly, incredibly short, and it's an incredibly effective procedure.
And I guess for the benefit of our listeners who may have seen One Flew Over the Cuckoo's Nest, it doesn't look like that. No. People are given muscle relaxants, they're given a general anaesthetic, and actually they're largely unaware that the procedure has indeed happened when they wake up. Yeah,
exactly. So certainly when I've had to deliver electroconvulsive therapy for people, I'll obviously introduce myself to the person, but I won't start doing anything until the anaesthetist who is there has made sure that they are asleep and there is muscle relaxant on board so that the person isn't aware of what is happening.
Yeah. So it's a much kinder treatment than it perhaps used to be if we look back.
Absolutely.
So you mentioned a delay for medication starting to work. Realistically, how long might it take a drug to take effect? Yeah,
so it obviously varies for some people.
Of course.
Generally, we say kind of 4 to 6 weeks. So don't expect to see a really good improvement for at least 4 to 6 weeks. Some people, it will be faster than that. But again, we don't try and jump to increasing medications quicker than we need to. But also some people, actually, we might find that they might not have improved within kind of 2 weeks, for example. And sometimes it might be a case if their depression is at that kind of that moderate to severe end, maybe we don't want to wait that 4 to 6 weeks. Maybe I'm thinking, okay, no, I'm just going to try something else because I need to get them quicker, better. But again, that's when you're thinking about someone being kind of in secondary mental health services. So that's something that a psychiatrist would be looking at rather than kind of a general practitioner or a non-psychiatrist within a hospital. Usually for them, I would say, once you've started a medication, I wouldn't think about changing it unless there are side effects and you need to stop it. Don't think about changing it for at least kind of 4 to 6 weeks.
And just ask, because I know occasionally we come across patients who are prescribed more than one antidepressant.
Sometimes that does happen. There is research that sometimes some particular combinations of antidepressants can be really good. So particularly you might see venlafaxine and mirtazapine prescribed at the same time. If someone's prescribed 2 antidepressants, they're usually 2 different classes of antidepressants, so they work in 2 different ways. I don't recommend that someone is prescribed 2 antidepressants of the same class. You're not going to get any more benefit and you're just going to give them more side effects.
So you can't supercharge the serotonin, for instance, by prescribing 2 SSRIs.
Exactly. One of the common ways that ends up happening is if someone is on an antidepressant medication but on it for something else. So some people are on amitriptyline for pain, not as an antidepressant. And then someone might come along and give them nortriptyline as an antidepressant. You've got 2 things trying to do the same thing. You're just going to give them side effects. Similarly, we often see people, as I said, on duloxetine for pain relief or for bladder problems. And then someone might then start them on venlafaxine as an antidepressant. Again, those are 2 medications that work in the same way. So you're not going to get any more benefit from it, but you are going to give them more side effects, so we don't recommend it.
Okay. Can I ask you about the relationship between antidepressants and suicide?
Yeah.
There's been much talk, I think, in the media over the years that certain drugs, I think Prozac is probably the one, or fluoxetine is probably the one people have been most familiar with, as increasing the risk. Yeah,
exactly. It's not a case that antidepressants increase your risk of suicide. And what we do know, your risk of suicide is greater if you have an untreated depression than if you're on antidepressants. There is some concern, and particularly in the kind of the younger population, so people in the kind of late teens, 20s, that when they first start an antidepressant, sometimes there can be a little bit of a spike in suicidality. What we think that's related to, though, is sometimes it can be the side effect of actually they just feel quite anxious and agitated. Sometimes we might think that actually it's the antidepressant has increased their motivation before it's increased their mood.
So it's returned the energy and the drive,
but it hasn't increased their
mood.
Exactly. So it is a risk for some people that we do tell them about, and they find that if that is the case, we tell them to please come back, seek medical attention for that. However, it is really, really important to stress that your risk of suicide is much higher if you're not treated for your depression. So I wouldn't not recommend an antidepressant for that reason.
So again, Emily, thank you very much for your time today. I'm sure that everyone listening to us today will have found this really interesting. And in case of any questions or any queries, again, there are resources available online. The Let's Talk website can be accessed at any time. And if you have any concerns about your own health, please consult your GP. If it's concerns regarding one of your patients, then please feel free to contact the liaison service, where we have psychiatric nurses and doctors who will be able to provide that expert opinion and advice. So thank you very much again for your time today.
Thank you.